So the next series is on juvenile rheumatoid arthritis, or JRA. JRA affects 300,000 children in the United States, and it's defined by or diagnosed by having joint inflammation and stiffness that usually lasts more than 6 weeks, and the children are either 16 years or younger. And so usually the onset of symptoms begins between the ages of 2 and 4 years, and they say that it's more common in girls. I have known more girls that have been diagnosed with JRA than boys, but I have known some boys too. It is an autoimmune disease, just like rheumatoid arthritis, where the immune system is attacking the healthy joint tissue, which causes that inflammation and pain and stiffness. The cause is unknown for JRA, but it may be genetically predisposed. Also, there's some talk about it being triggered by certain environmental factors, such as viruses or a certain kind of virus at a certain stage in life. So there is some talk about that. Signs can be very subtle, or they can be very obvious. Limping is often an early warning sign. Kids may complain of sore wrist, fingers, knees, and joints may swell up and become enlarged. They're going to feel warm, and again, kids may be complaining that they hurt. There's sometimes you'll see stiffness in the neck, so them having a difficult time turning their head from side to side, with their hips maybe standing up from a chair, and possible other joints as well. JRA, sometimes you'll see rashes, or fever, different things like that, swelling of lymph nodes. JRA also can inflame the eye. In particularly, it's a specific type of JRA that affects the eye. In severe cases, the growth of the affected joints may be too fast or too slow, which would cause one limb to be shorter or longer than the other. Flare-ups are active periods that flare-ups are active periods where the arthritis is acting up, where they're having symptoms at that time, and that's called a flare-up. Remission is an inactive period where the arthritis doesn't seem to be causing symptoms at that point. I remember a little girl I worked with. She was 2, and she was, happy-go-lucky, beautiful little girl, bubbly little 2-year-old, and all of a sudden she started to limp and kind of drag her right foot. And her mom thought, well, gosh, this is, she must have just landed on it wrong when she was running around in the yard and that sort of thing. But it didn't get better. And then mom started noticing a rash behind her knee, which is in that popliteal area, and that's kind of an indicator of arthritis too. And so, she also started noticing some redness in her ankles. And of course, this all takes a while. She's like, oh, she'll shake it off. She's a tough girl. And then all of a sudden it's getting worse. And then you can physically see the inflammation and the swelling in her. For her, it was more so her ankles. And then we started noticing it in her wrists too. Because of her age being 2, she couldn't say that, oh, my wrist is sore. But when she was starting to show some delay with fine motor skills, and anytime they would have her do something like try and put a puzzle together or a shape sorter, she would rub her wrist, or she would shake out her hands, or she just would refuse to do something like that. And so she also started getting low-grade temperatures and just complaining of being tired a lot. Or she didn't complain of being tired, but they noticed that she was taking naps on her own. And hard to wake up, and she just wasn't herself. And so eventually they did get the diagnosis of JRA. When they do diagnose it, they get a medical history and a thorough examination. They do x-rays to take a look at the joint's integrity. They do blood tests to rule out other conditions with other symptoms or with similar symptoms, like just a physical injury. You know, did she twist her ankle? Or is there an infection going on? Is it Lyme disease? It could be something systemic like lupus, or again, it can be cancer as well. Other tests they might do is a CBC, which is a complete blood count. And so they'll be looking at all the cellular components of blood, including red blood cells, white blood cells, platelets. And so abnormalities and appearances of these cells can be useful when diagnosing many other types of medical conditions. The erythrocyte sedimentation rate checks how rapidly red blood cells settle to the bottom of a test tube. The rate often increases in people when inflammation is occurring in the body, and so this can be kind of a red flag for JRA, or it can kind of point you in the right direction. ANA is anti-nuclear antibody, and it's a blood test to detect your autoimmunity. So it's useful in predicting which children are likely to have an eye disease for JRA. So again, anti-nuclear antibody, ANA, is used to predict if an eye disease is going to be indicated. They can also do a bone marrow examination, and this is to rule out conditions like leukemias. And they can also do bone scans to detect changes in bone and joints and evaluate any causes of unexplained bone pain or joint pain. So as I mentioned before, there's different types of JRA. Pauciarticular JRA affects 4 or fewer joints. There's few or no systemic manifestations. So usually there's no fever or no rash. It usually affects girls under 8. Hips, knees, ankles, and elbows are most often affected, and it often affects joints just on one side of the body. The iridocyclitis is that chronic eye inflammation that can lead to blindness if this is not treated. So again, children with pauciarticular JRA need that regular screening for eye inflammation. And again, if they're checking, or they'll do a blood test to check that anti-nuclear antibody, so that anti-nuclear antibody, and if that's positive, then they found that they're likely to have that inflammation in the eye. Overall, the prognosis is fairly positive because few joints are affected, and typically with pauciarticular JRA, they're more likely to go into an early remission. So polyarticular JRA, the onset can happen at any time. It affects more girls than boys. It affects 5 or more joints, and it usually affects the small joints of the hand, as well as the knee, the hip, the ankles, the feet, and the neck. It is it does have a low-grade fever, or it is accompanied with a low-grade fever and malaise or fatigue, being very listless, and it's symmetrical, so it's going to happen on both sides of the body. There's an antibody, IgM, which is the rheumatoid factor, and so it's another blood test that they're getting. They're looking for antibodies, and the more antibodies you have, the more severe this type can be. So if there's a negative rheumatoid factor, the prognosis is good, but if the rheumatoid factor is positive, there's an increased possibility of disabling arthritis. And so I believe this was the type of arthritis that the little girl, one of the little girls I worked with had. She fit pretty much every category on here, except her rheumatoid factor was relatively low, and she did go into a remission. There's systemic JRA, and this one has an equal male to female ratio, has an onset at any age, and it affects the entire body. This is the least common form, and they have a really high fever. During the fever, children may feel very sick, appear pale, develop a rash, or get red pale spots and blotches all over their body. The spleen, liver, and lymph nodes may also become enlarged. And over time, many of the body's joints are affected by the pain and the swelling and just being really, really stiff. A lot of times they will have a high white blood count. They will be anemic. And the prognosis, about 50% of them develop more severe chronic arthritis and have reoccurrent manifestations with inflammation or an inflammation, that sort of thing. Doctors will often prescribe corticosteroids. Usually, there's also some medications that are being used out there for smaller doses for children with JRA. And they have some nasty side effects, and you aren't supposed to use steroids for long periods of time. And so I know the little girl that I worked with, because she was so young, the mother really had a lot of issues with her JRA meds, plus being on corticosteroids, and when to take a break and when to stay on them and start them up, because you don't want a flare-up to occur. So what we do in OT and medical treatment, for that matter, if there's anything we can do to control inflammation, is there contrast baths that you can do? Those are relatively safe, that you can teach families how to do that. That's soaking your extremity in warm water, and then cool water, and then warm water and cool water. The whole idea is to when you soak your extremity in warm water, you open up the blood vessels, the muscles relax. You dip them in cool water, and your blood vessels and muscles constrict. And so when they constrict, you're constricting that fluid and hopefully pumping that fluid out. So by alternating in warm and cold and warm and cold, it's acting like a pump to get the edema and inflammation down. Also, if you elevate the extremity, relieving pain is also something that we can do. Again, with some simple modalities, whether it's, now with arthritis, we have to be careful. And I'm not going to go into it too much, because I know you'll learn your physical agent modalities in next year. But weigh out the use of hot packs, or a nice gentle heating pad. I mean, we know that rheumatoid arthritis is an inflammation, or is an inflammatory, and so we should want cool temperatures. And so, but a lot of times our clients say, oh, well, heat feels really, really good. And so that's something that you'll have to decide as a clinician. You'll have to outweigh the pros and the cons. And again, when you're working with really young children, some of the modalities is contraindicated. And so that's something I usually have parents kind of play around with and experiment with, and see if, wrapping their joints in something warm, or a warm pack or a cool pack, or alternating between the two, if that helps relieve pain and helps control the inflammation. Some other things you can try to help relieve pain, in the little girl's wrists, we gave her a soft Bennett hand splint. So it gave the wrist just a little bit more stability, and the Bennett hand splints are made of neoprene, and so it provided some compression. And so the compression would prevent any swelling from happening in that area, or it just kind of helps it make it feel good. Kind of along the same theory as if you slam your finger in a door or hit it with a hammer, the first thing people do is they rub it, or they put it in their mouth to relieve the pain. And why that works is that light touch kind of overrides that that pain pathway that's going on. And so by having that neoprene compression and deep pressure, you're hopefully overriding that pain response a little bit. Certainly in our treatments, we want to prevent and control the joint damage. And so maybe putting a built-up handle on utensils, or built-up grips on a writing utensil, different things like that to prevent that further joint damage. And then we want to maximize their functional abilities as much as possible. Help them be as independent as possible. Have them use adaptive equipment, maybe long-handled equipment for dressing, or use of Velcro closures, different things like that to, again, maximize their independence. Naproxen, I believe, is a medication. That's an NSAID pain reliever, just like aspirin, ibuprofen. It's kind of an anti-inflammatory. Corticosteroids like prednisone help manage the inflammatory systemic part of the illness. And then methotrexate, that's the medication that the little girl was on in a smaller dose. And the side effects to that, Mom was really leery about. But it's disease-modifying anti-rheumatic drugs. And so again, methotrexate is a popular one. With OTs, we're going to focus on activities of daily living, helping people be as independent as they can on whatever is age appropriate, looking at any adaptive equipment, energy conservation, range of motion, splinting, things like that. Physical therapy, maybe looking at range of motion also, maybe doing strengthening and endurance exercises as well. Exercise is okay, but we can't over-exercise because that's going to increase joint inflammation and that sort of thing. But if you stay sedentary, that's going to cause more stiffness too. And so it just sort of, you have to weigh out that balance. Seating needs to be monitored to help reduce fatigue and prevent any harmful pressure on joints, things like that. So any seating and positioning types of things you may also do. And any complementary and alternative medicine has been used also. So the family that of this little girl, they had her go to, they would see an acupuncturist. I couldn't think of what the term was, but and some of the chiropractors and stuff do acupuncture, and so they were able to do that. Certain diets, there's some foods that are natural anti-inflammatories, and providing different supplements as well. Let's see here. This is just to do on your own, kind of a hands-on lab activity for you to think about JRA. You have a 10-year-old boy in an acute case of polyarticular JRA. He has decreased fine motor dexterity, causing problems with dressings. And so some strategies to assist, having the child wear pullover shirts, elastic pants, maybe adapting a shirt with Velcro, teaching the child to close snaps with the palms of his hands so he's not putting so much pressure on his IP joints, and using zipper pulls, because you can use more of a gross grasping technique or radial grasp with that versus a pincer grasp, which can put a lot of pressure, again, on those IP joints. The prognosis varies in a wide range. The largest percentage of children with polyarticular JRA recover completely within 1 to 2 years. The little girl I saw, she was completely in remission and caught up developmentally within about 1.5 to 2 years. About 15% of all children with JRA have some type of permanent disability. None of the kids that I worked with, I think I worked with 3, maybe 4, and none of them ever had any permanent disability. They all went into remission. So, story, here we go. Here's the case story on your own for lab. So Samantha, 7-year-old, she likes playing outside, dancing, being with her family. She started to have pain in her knees, ankles, and elbows. She holds her arm in that flex position as that seems to feel more comfortable. She's in an acute phase of her JRA. which is the beginning stages. She saw the doctor and she was diagnosed. So something to point out in this particular case, a lot of times when kiddos feel pain, they're going to be in that flex position or that fetal position because that's what's more comfortable. And we really have to be careful with that. We want to get them out of that flex position because if, say she's having, we're just going to focus on the elbows. So she has her flexed elbows and she has her wrist kind of up by her chin or across her chest. Our bicep gets really, really tight and can get really tight because that's in its shortest position. Whereas when our elbows are flexed, the triceps are in the longest position. And so if you sustain that position over time for long periods of time, it's going to get more stiff. That bicep is going to need to be stretched and the tricep is going to be too loose to really fully contract. And so then you're going to have some of that weakness. So again, what type of JRA does Samantha have? I kind of went over number 2. What are your concerns regarding her flex posturing in her upper extremity? We call that soft tissue shortening. If it's in the shortened position or that muscle's in the shortened position, the tissue would eventually shorten. And then it would cause further joint deformity, more pain, more inflammation or stiffness. Will Samantha, do you think she'll recover? And are there any activities you would avoid? So just kind of some things to help you study and to go through the PowerPoint. Here's some additional resources for you. AOTA has information, American Academy of Pediatrics, and National Institute of Arthritis and Musculoskeletal and Skin Disease.